Welcome, everybody. I'm really happy that you are with us today. We are really honored. This webinar is not just another webinar about the treatment of venous problems. We consider this a real scientific bridge between two continents, Latin America and Africa. And we're really looking forward to collaborate and to share with our African neighbors the science, technology, and the joy of treating venous problems according to evidence-based and guidelines. Today's theme is thermal ablation. We are all familiar with thermal ablation. It's something that we nearly do every day. But what's special today is the speakers. We have distinguished speakers, Professor Lowell Kabelnik of the United States, Professor Francesco Zini of Italy, and both will be presented in detail later. I'm really honored to present our guests of honor, Dr. Ashta Hamadou of Cameroon and Professor Ali Mourad of Egypt. They will be presented in detail a little later. We cannot proceed without mentioning the efforts of Professor Sergio Genassini. Professor Genassini is professor at Ferrara University and at Bethesda University, United States. Professor Genassini is a great font of evidence-based. He's a great team player on a global scale for the purpose of promoting education in the field of venous and lymphatic diseases. I must say that without him, nothing would have happened in this webinar. We're really thankful to Dr. Genassini. Professor Oscar Bottini is a great man. He spared no effort in helping us build this bridge between Latin America and Africa. We really appreciate your efforts, Professor Bottini. I'm really honored to present our esteemed panelists. They are very distinguished panelists, and they are going to present it one by one later in the session. Nothing could have been possible without the unconditional sponsorship of our sponsors, our main sponsor, Servier Daflon, our gold sponsor, Medtronic, and our support sponsors, Abbott Biolytic and Promed. Thank you to every one of them. Finally, I would like to announce our award, which is $500 towards travel expenses, plus free registration for the World Expo of Dubai, which will be held in January 2022. This is going to be given to the best question or comment. The questions are going to be recorded and filtered later. I would like to give the word now to the secretary of our foundation and my longtime colleague, Dr. Wasila Taha, who really worked extremely hard to make this possible. Dr. Wasila?
Thank you, Dr. Bishara, for such nice introduction. All the honor is mine, really, to work with you along the way. And nothing would happen without the team. Players win games, but the teams win championships. And now I'm really honored to be part of such a spectacular journey between the two continents, between Latin America and between Africa, under the name of LATAF, which is meaning something very nice in Arabic words. And I have really very delighted to introduce our guest of honor from Africa today, Dr. Ashta Hamadou. Dr. Ashta Hamadou, she is the former Chief of Health Structures in Cameroon, coordinator of priority programs and the surveillance for the Centre Pasteur, member of the Technical Secretary of the Scientific Council for Public Health Emergencies, and she has a lot of responsibility. And the best part, nowadays she is the head of planning section of the COVID-19 response in Cameroon. And now we will have the video recorded by Dr. Ashta Hamadou. Please, Khaled.
I could not take the floor without thanking my friend, His Excellency Ambassador Medat, who through his particular commitment to Cameroon is at the origin of my presence today. Good evening, dear members. The issue of thromboembolic disease constitutes a real health problem in Cameroon. Even though they are frequently encountered and diagnosed, the statistical data remains very low. A study appeared in June 2019 and carried out in 3 hospitals in the capital revealed a prevalence of 1.6% of venous thromboembolysis. The predominant factors in this case are in order of severity: cardiovascular factors, then come neoplastic and obstetric risk factors, post-surgical factors, and finally the reactive C protein deficient, representing 2.5% of the case of the study population. The disease is frequently diagnosed in a young population with an average peak between 51 and 60 years old. Venous thromboembolysis is common after 40 years of age and is usually predominantly female. Finally, I just want to take this opportunity to say that those disease is still underdiagnosed in sub-Saharan Africa in general, particularly in Cameroon. Hence, the need to strengthen the capacity of medical personnel in training. In Cameroon, just 2 vascular surgeons are in activities. Thank you for your kind attention.
Thank you, Dr. Wasila. Now it's my pleasure to introduce Professor Lowell Kabnik. Professor Lowell Kabnik, we all know him. He's an international authority on the diagnosis and treatment of venous diseases. He is Vice President of UIP North America. He's Associate Editor in the Journal of Lipology. He's past President of the American Venous Forum. He's Director of New York Vein Center until 2018. But maybe most relevant to his talk today, that he was the first surgeon in the United States to perform thermal ablation long time ago. So maybe he's one of the most experienced surgeons worldwide. He was elected top doctor in the Guide to America Top Doctors. He has very many publications. Many of them are considered landmark publications and textbooks. Professor Kabnik. Dr. Kabnik, are you with us? Please unmute yourself.
Okay, thank you. Thank you for the introduction. And I would like to thank Rashad Bashara, Wasilia Taha, VWIN, and the organizing committee for inviting me to present on 20 years of endovenous thermal ablation. I performed my first case of radiofrequency ablation in May of 1999. It was quite different then. Pullback of the catheter was very slow, and it took about 30 to 40 minutes. Then laser became available, and the speed of pullback was much quicker, with more discomfort, bruising than radiofrequency ablation. However, all of these devices have been improved and are now with clinical equipoise. Here are my disclosures. The following are just my opinions. There are many ways to treat the intended issues. In this presentation today, I will talk about complications of endovenous thermal ablation and the new American Venous Forum and Society for Vascular Surgery endothermal heat and induced guidelines. So let's talk about complications and tell it like it is. I went online to see what was listed for complications, and Wikipedia came up with an early Australian review. These complications were divided into major and minor. Temporary numbness was listed at about 4%. Skin burns were 0.5%, DVT 0.4%, and nerve injury about 1%. A rare complication with laser is retinal damage. Fortunately, I've not seen this or heard about anyone that has experienced this. Here is a user error, case of embolized fractured wires and laser fiber. If you look closely, you can see the artifact by the red arrows. This is a radiofrequency case, which one of my colleagues referred to me. This patient was a 35-year-old malpractice attorney who underwent bilateral radiofrequency ablation. She was extremely upset After review, it was apparent that both the great saphenous vein and the superficial accessory saphenous vein were ablated. I cautioned my colleagues about thermal ablation of the superficial saphenous vein. With my second radiofrequency ablation case in April of 1999, I caused an exit site burn. Yes, my radiofrequency ablation catheter was too close to the exit. I treated the burn by excision and she healed well and remains in my practice today. Other skin burns have been reported, but should be rare with proper selection of patients and tumescent anesthesia. So let's look at some data. Here is an early registry many years ago that I put together from various reporting countries. There were about 4,000 patients. The paresthesia rate was about 3%, burn rate was 0.5%, DVT rate was 0.3%, and PE was 0.02%. Dr. Vanden Bos from Holland and her colleagues reported in 2009 a systematic review, endovenous laser ablation, induced complications. In summary, DVT and nerve injuries occurred in about 1%. So let's look at some of my case study complications. This is a 56-year-old female with symptomatic varicose veins. She had a previous history of intermittent swelling without any other comorbid conditions. On physical exam, she had varicose veins and no swelling. Her duplex ultrasound revealed right great saphenous reflux from the saphofemoral junction to the proximal cap. She underwent a laser procedure using a 1470 nanometer EVLT angiodynamics laser with a covered fiber never touch. Post-op at 1 week, she complained that you caused my foot to swell. Her duplex exam revealed that the great saphenous vein was closed with no further reflux. There was no DVT or E-hit. On inspection of her right foot was swollen, minimal pitting, and here's what I observed. And you can see that her preoperative foot looked normal, and this was her postoperative foot. So of course I went to PubMed, and this is the only article that I could find. Is there a risk for lymphatic complications after endovenous laser treatment of the great saphenous vein? The authors concluded that this study demonstrated that no lymphatic complication occurred after EVLT. 3 years later, she returned to my office for right leg discomfort when standing. She had no swelling. Her follow-up duplex of right leg revealed no further venous pathology. Here's another case. This is a 68-year-old female with symptomatic varicose veins of the left thigh. Her duplex demonstrated great saphenous vein reflux within the fascial compartment to the mid-thigh, and then epifascial accessory vein to below the knee. Radiofrequency was performed, entry site below the knee, extra tumescent anesthesia was placed around the vein in the epifascial area. Originally, the target vein was under the skin, and post-tumescent, the target vein was 1 centimeter below the skin. 1 week post-operatively, the great saphenous vein was closed and there was no evidence of E-hit. She was complaining of pain in and around the epifascial vein, and there was a palpable cord. No erythema, and at 3 months post-op, the ultrasound revealed a closed great saphenous vein. And as you can see, there is skin retraction secondary to the phlebitic reaction on the superficial saphenous vein. This is another example about being careful with thermal ablation in superficial veins, regardless of the amount of tumescent anesthesia. Here's an awful complication, septic phlebitis. Immediate excessive drainage is necessary. This patient did well according to the article. My colleague and I reviewed the literature and reported our cases of arteriovenous fistula. We identified 3 cases out of a pool of 2,500 endovenous ablation procedures, yielding less than a 0.15% incidence. 2 from radiofrequency and 1 from laser. 2 great saphenous veins and 1 perforator vein. 1 arteriovenous fistula occurred between the sural artery branch and the medial calf varicosity, which closed spontaneously at 18 months. 1 arteriovenous fistula with radiofrequency and 1 with laser involved the external pudendal artery branch and the great saphenous vein. 1 closed spontaneously at 11 years. The other one I followed for 8 years without incident. We can postulate that these arteriovenous fistulas occurred secondary to the tumescent needle and/or thermal injury. So finally, let's talk about EHIT. Today, I bring you an abridged version of the soon-to-be-published classification treatment of endothermal heat-induced thrombosis, recommendations from the American Venous Forum and the Society for Vascular Surgery. In 2006, I presented the American Venous Forum the classification and definition of EHIT. After analyzing many cases from 3 different institutions, it was certain that there was different patterns of extension. The American Venous Forum Guideline Committee organized an EHIT writing group to analyze the available literature regarding EHIT, to gauge the quality of clinical evidence, and to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the American Venous Forum and Society of Vascular Surgery and accepted into publication in October in the Journal of Vascular Surgery and Venous Lymphatic and the Journal of Phlebology. We looked at both Kabnick and Lawrence classifications and were able to translate the data as the descriptors are quite similar. Thus, the AVF updated the EHIT classification by adding to EHIT 1, thrombus without propagation to the deep vein. We added A, peripheral to the superficial epigastric vein, and B, central to the superficial epigastric vein, up to and including the deep vein junction. There are about 15 guidelines with regards to EHIT. With the time limitations to this talk, I've selected some, but not all. Let's start off with Guideline 2.1, risk factors for EHIT. Some possible but inconsistent predictors or risk factors for EHIT include large great saphenous vein diameter, previous history of venous thromboembolic disease, and male sex. These may be considered in the pre-procedural phase, but the evidence is inconsistent. We grade it as grade 2C. Guideline 2.2, prevention of EHIT with chemical prophylaxis. The use of chemical prophylaxis for the prevention of EHIT should be tailored to the patient after an assessment of the risks, benefits, and alternative. Grade 2C. Guideline 2.4, prevention of EHIT by increasing ablation. There is a trend toward a decreased EHIT when ablation is initiated greater than 2.5 centimeters from the saphrophrenoidal junction, or the saphenopopliteal junction. Grade 2C. Grade 3.2, treatment for EHIT 1. Just as you would think, we suggest no treatment or surveillance. Guideline 3.3, treatment for EHIT 2. We suggest no further treatment of EHIT 2, but with weekly surveillance until resolution of thrombus retraction. Grade 2C. As an alternative for EHIT 2, consideration may be given for antiplatelet therapy or anticoagulation for EHIT 2. Weekly surveillance with cessation of treatment following thrombus retraction to the saphrophrenoidal junction. Grade 2C. Guideline 3.4, treatment for EHIT 3. We suggest treatment with anticoagulation for EHIT 3, weekly surveillance and cessation of treatment following thrombus retraction to the saphrophrenoidal junction. Grade 1B. And lastly, Guideline 3.5, treatment for EHIT 4. We suggest that treatment should be individualized, considering the patient risk factors, bleeding risk, and reference may be made to the CHEST guidelines for the treatment of a provoked VTE, grade 1A. And with that, ladies and gentlemen, thank you very much for the opportunity.
Thank you, Professor Kabnick. Actually, those guidelines are going to be published next month. So thank you very much for giving us, prior to publication. We really appreciate it. Now may I ask Dr. Wasila to present our esteemed panelists. Dr. Wasila.
Thank you, Dr. Rashad, but not before to congratulate Professor Kabnick for such a spectacular presentation, excellent and brilliant presentation, Dr. Kabnick. And I'm deeply thankful for your continuous effort, what you do in Egypt for the vascular community and your continuous support. I think, Lower, you can ask for the Egyptian nationality now. I think so. You have the right now.
Thank you.
Thank you for your effort. Now I'm really delighted and biased also because I will introduce a very friend of mine, Dr. Chantal Aguirre. Dr. Chantal Aguirre from Paraguay. She's director of Clinica Vanguardia Clinical and Research Center for Venous and Rheumatology Disease. And she's past president of Paraguayan Society of Phlebology and Lymphology. Chantal, the podium is yours now.
Thank you, Wasila. Thank you for the opportunity to be part of this project that joined these two continents. I'm happy to be part of it and listen to Dr. Kapnick that he is also a major figure for us, and the laser topic is in our mind all the time and in our clinic. I would like to know if after all these techniques and these years that you are performing this surgery, we still have some doubts about prophylaxis. I don't know if we can use normally in some patients with risk factors. What do you use for it? Do you use rivaroxaban, stockings, NSAID, medication? When you talk about chemical medication, how long do you use it? I know you used to do ultrasound surveillance after the procedure. It's difficult to do it in my country, and I know you also think that it's not necessary for economic reasons. I would like to know your opinion about it.
So I will give you my opinion as opposed to the guidelines opinion. So my opinion about duplex ultrasound is it's worthless post-op. We know that 97% or the high 90 percentile, our veins are going to be closed. Even if the vein is closed and the patient has no symptoms, I don't need to see that patient. Number two, EHIT2, I've not treated for a long time, so I don't need to follow that. In terms of patients that are high risk for thrombosis, we do evaluate the risk factors, but we very rarely give any type of systemic medication, chemical. We certainly have the patient wear compression, but for those patients that had a previous DVT, or for those patients that have thrombophilia, we will prophylax them at the time of the procedure with a shot of Lovenox. Now, typically we follow those patients with Lovenox daily prophylactically for at least 10 days, because the only literature that we have is the plastic surgery literature, which is 10 days, and the orthopedic literature, which is 30 days. For short of that, if people do 24 hours, it's not worth it. Now, there's some talk about giving the DOACs pre-op and post-op, although there's only one or two papers. One was by Dennis Borsak. So I think that still needs to be investigated. Thank you for your questions. I really appreciate it, Chantal.
Thank you, Dr. Kapnick. A pleasure.
Yes, so we'll move to the next panelist, our compatriot, Professor Ayman Fakhri. He is the president of the Egyptian Venous Forum from 2013 till current, General Secretary of Vascular Society of Egypt from 2015 till current, member of the board of the Egyptian Fellowship for Vascular and Endovascular Surgery, and with Dr. Omar Al-Farouk, really they do great work with the VOT training channel, educational activities. Very early they were pioneered for this during the lockdown, the local total lockdown of such a scaring COVID-19. Thank you, Professor Fakhri, for all you have done. And now the podium is yours. Professor Fakhri, please.
Thank you, Dr. Wasila, for this nice introduction. Thank you. And I appreciate your all efforts, you and the Professor Rashad Bishara, for keeping on medical education in Egypt. I'd like to thank Dr. Lowell Kabnik. Very nice presentation. Indeed, we always enjoy your lectures, Lowell. My question, do you think there is biomarkers that could predict the instance or developing EHIT during the venous ablation, laser ablation?
So we've not looked at biomarkers at all for EHIT. That might be something we would do, but I'm really not concerned with EHIT anymore. I think over the history of EHIT, and now we're looking for 20 years following the natural history, the amount of pulmonary emboli that occur from a standard thermal ablation are extremely rare. The amount of DVTs that are persistent are extremely rare. So I'm not sure that we need to actually look at these anymore. That may be different with some of the new non-thermals that we're engaging. For example, cyanoacrylate. We don't know the natural history of those yet, but that may be something interesting to look at going further. But for thermal, no.
Great, thank you.
Professor Oscar Bottini, are you with us? Professor Bottini, are you with us? Okay. Dr. Asira,
Yes,
please.
yes.
Dr. Bottini, are you with us?
Present. Let me introduce Dr. Hama Hashet. Su pregunta. Your question.
Dr. Ahmad Gawish, please,
Yeah.
your question
Yeah.
to Professor Kabnik, please.
Hello, Dr. Lowell.
Be gentle,
Thank you
Dr. Ahmed.
Yeah, sure. Thank you for a great presentation as usual. I have just one question for you. Talking about EHIT and DVT, which as you showed in your presentation, have their incidences quite low with endothermal ablation. However, given that we're dealing mostly with patients who are not severely complaining and where usually complications are both unforgiven and unforgettable, what do you think about a practice of giving routine prophylactic anticoagulation by a DOAC post-ablation for 2 weeks? Is it justified in patients with low bleeding risk? Are you inclined more to support this, or you oppose it, and why?
So the simple answer is no, I don't support it. And two, the majority of patients don't need it. And to find somebody that has one problem versus the number of people that you're treating, I think is a waste of finances.
Okay. Thank you.
Thank you. Dr. Asira, could you please select a question or two from the...
Yes, Dr. Rashad, we will select the questions according to the most liked ones. So the first one from Dr. Daniel Fuchs, and he said, excellent presentation and greetings to Lowell from Argentina. My question is, what did he do with the patient who presented the fiber fracture? Did he remove it or expectant behavior? How often do I follow up with echo Doppler? And then greetings, excellent dissertation and topic. Dr. Kabnik, please, your answer.
Thank you very much for that question, Dr. Fuchs. I did not cause those problems. They were picked up on the internet. I just wanted to be all-inclusive. So I don't have any experience with fractures and retrieving them. I do have experience with a burned sheath from one of my residents while doing a small saphenous vein ablation, which he pulled the fiber back into the sheath, and actually the sheath burned. So I came out with a half a sheath. And through ultrasound, I was able to extract it through a very tiny incision. However, the patient was still not happy.
Yes. Do you think it has a relation with the the times, because sometimes they do use the catheter fiber for so many patients, yani frequently, much more than once time. Do you think it's proportional, the fraction of the fiber is proportional for how frequent it's used?
So it has to do with that. I think that's a great point, Vasilia. I also think it has to do with technique. People with radio frequency that have gone to laser have always thought about the idea of compression. In radio frequency, the thermal device transmits by conduction. In laser, it's convection, conduction, and radiation. So the object of pressing on the vein is not indicated, and that's where a lot of fractures occur.
All right, thank you, Lowell. Moving to the second question from Dr. Ayman Esther.
I'll have to interrupt you for the sake of time. All the questions are going to be recorded and
You cannot take just one?
So now we Dr. Wasila have a little surprise with us. So go ahead, Dr. Wasila.
Well, the surprise, we celebrate today the birthday of Dr. Das from India. And we can see on this slide, friends from India, Dr. Pinjala, and here the guy of the birthday guy, Dr. Das, and friends, also Sergio Giannesini, a very good friend. We never miss this opportunity. We were in Fortis Mohali, the great course of conducted by our dear friend Rahul Jindal, and here also a good friend from Chile. So happy birthday, Dr. Das, and we are really happy and delighted having you among us today to celebrate your birthday. Happy birthday.
Happy birthday, Dr. Das. We're wishing you very nice days to come. And now we move to the second part of this webinar, and it's really my great pleasure to introduce Professor Francesco Zini of Parma, Italy. I first knew Professor Zini in this humanitarian mission in Santo Domingo. This was today's work. This was the work that Professor Zini would have to do in one day. Professor Zini is actually involved in many such humanitarian activities in Latin America and around the world. In addition, of course, he has many professional contributions, and I would like to emphasize his most important contributions related to today's talk. He started being interested in modern vein therapy very early on, like in 1982, he was a great promoter of prostatectomy and stripping under local and regional anesthesia. In 2004, he adopted the newer techniques of thermal ablation, and in 2015, he published his own technique of SFALT, which he's going to talk about today. SFALT is a very interesting technique that combines foam and laser. Professor Zini, please go ahead.
Good evening to everybody. First of all, I would like to thank you very much, Professor Rashad Bishara, for the invitation and for the kind word of presentation he had for me. The subject of my presentation is SFALT, sclerofoam assisted laser treatment. This is my disclosure. And during the last decade, the landscape of treatments for venous chronic insufficiency has completely changed. New endovenous procedures have come up with good clinical and aesthetic results. In the United States, from 2004 until 2010, crossectomy and stripping went down to near zero. And in the same time, radiofrequency and laser grow up to 35 and 60%. We have now, in 2020, a lot of possibilities to treat varicose vein and chronic superficial venous insufficiency. We have MOCA, mechanical-chemical treatment, like Phlebogriff and Clarivane. We have foam, of course, spread all over the world. We have different kind of glue, and laser and radiofrequency that were the first that came up on the screen in 2000. Among them, there are 4 treatments that are so-called mixed treatment. Clarivane mechanical and sclerosing liquid, and Phlebogriff mechanical and sclerosing foam. The mechanical part of this treatment is to destroy the endothelium so that the sclerosing agent can attack the endothelium much harder. Then we have LAFOS, holmium laser that shrink the vein, and then sclerosing foam, and SPHALT. It is a mix of sclerosing foam and laser 1500. SPHALT is an acronym of sclerofoam assisted laser treatment. This is a personal innovative technique without tumescent anesthesia to treat saphenous refluxes and to obliterate saphenous vein in superficial insufficiency. In Italy, we have 6 private and public hospitals that use this method, and until April 2019, in 4 years and a half, we treat more than 1,500 cases. Also in Brazil and in China, someone treat, we have some followers with laser without tumescence and this combined treatment of laser and sclerotherapy. The main step of this procedure are this that are shown in this short video. The first part is like all the procedure in the vascular procedure is the insertion of a catheter into the vein and the fiber that is located 1-2 centimeters below the epigastric vein near the saphenofemoral junction. The first step is to close the saphenous vein in a very hard way with the 200 or 250 joule. We prepare the foam and we inject the foam. As you see, the foam shrink the vein more than 50% of the diameter of the vein. And then we use laser, we pull back the fiber with more or less 50% of the fluence of the laser. If you ask me, SPHALT, is it more effective and which are the advantages, I can answer that the results that we observed so far give an affirmative answer in terms of recanalization that are less than 1%. And we didn't observe peri and postoperative complication. So which are the benefits? After the closure of the saphenous vein at the saphenofemoral junction, the foam that we have injected fills the saphenous trunk completely. We can check this with the echo-color control. The foam acts immediately on the endothelium in 8-10 seconds, and the first result that we obtain is an optimal and risk-free sclerotherapy of the saphenous vein, without migration of bubbles, air or gas, because the saphenous vein is closed, without migration of sclerosing liquid and endothelial catabolites into the deep venous system. We could stop here like most of our colleagues in France and Europe do, because this would be a very good foam sclerotherapy of the saphenous trunk. The foam that we have injected also spread into the refluxing saphenous collateral veins, and they complete the treatment, decreasing the need of phlebectomy. Sometimes it is specifically pushed with the probe of the US unit. The foam is pushed into a pelvic reflux or in a perforator, anterior perforator, and we reduce so the possibility of recurrence. We can say that there is a double synergic action on the endothelium from the foam and on the vessel wall with laser. The production of foam takes really a few seconds to the place of tumescent anesthesia, which is quite long to prepare and to inject, and is painful, and causes the foam a uniform spasm of the vessel. More than 50% of the vessel, independently from the concentration, the amount, and the type of sclerosing liquid. We didn't realize any difference between 0.5% of foam with sotorolol or polidocanol and 3% in the shrinking property of the foam. The laser fluence is decreased by 50% of normal value, with a lower risk of carbonization, of thermal involvement of the surrounding tissues and of the nerve, especially in the external saphenous vein, and a much lower pain stimulus. Postoperative pain is absent, and we observe a drastic decrease in tight postoperative ecchymosis. So very good results from the aesthetic point of view. Endovenous laser at 1500 nanometers and radial fibers is a very minimal invasive procedure. Literature reports up to 52% of painful and not aesthetic hematomas or ecchymosis along the treated saphenous area after laser with tumescent anesthesia. And for us, there is not correspondence between the mini-invasive approach of laser and the large amount of liquid that is injected into the fascia with tumescent anesthesia. Tumescent anesthesia is referred from patients as the only very painful time of the intervention. In addition, the vein compressed into the groin and between the saphenous fascia from the liquid of tumescent anesthesia is not visible anymore, and therefore no longer monitored with the US unit. We must know what happened into the vein while we close that. We have to see if the fiber works well, if there is a perforation, or if it's too low and we don't have any effect on the wall of the vein. This is a cornerstone of security of endovascular procedure. And then tumescent anesthesia is not free from potential complication. There is a short video in which you can see that you can tie a knot with the fiber, or you can rub it on the table and nothing happens. But if you touch the fiber with a needle, or if you touch the fiber with a blade, then the fiber suddenly broke. Probably, I'm not sure, but this is the explication of more than 20 works that are in literature with the fiber that broke during laser procedure. So we don't like tumescent anesthesia. We don't use tumescent anesthesia. Tumescent anesthesia is used normally to reduce the diameter of the vessel, to protect the surrounding tissue, and obviously also for anesthetic purpose. And you reduce the diameter with the spasm due to the sclerofoam. We protect the surrounding tissue. We don't need to protect surrounding tissue because we use less than 50% of fluents, and we use sedation for anesthetic purpose. Well, why sedation? The intravenous sedation has become a daily practice in first aid, orthopedics, and endoscopic units. And patients appreciate a lot not to feel any pain or injection and the discomfort of operating room. We think there is a strong indication for this modern type of endovenous anesthesia and the endovascular laser, considering the algic time is only 5 to 10 minutes. The procedure must be performed in an appropriate room with the presence of an anesthetist. Here are my personal cases from October 2014 to April 2019. 845 treated limbs, mean age 55 years old, 68 female and 31 male. Great saphenous vein 80%, short saphenous vein 15%. Very few complete recanalization, some partial recanalization, and quite a lot of refluxes in accessory anterior saphenous vein, like I think every endovascular procedure. So we can say that at mid-tide, the great saphenous vein caliber decreased more than 50%. There was no statistical difference among Sotra-Decol and Polidocanol. At follow-up controls, 20 days, 3 months, and 1 year after SPHALT, all patients presented shrinkage, occlusion, and frequent disappearance of the vein. Only 3 complete recanalization. Neither major or minor complications were reported, and very few ecchymosis and hematomas were detected at the tide. In conclusion, this treatment, this SPHALT treatment, is extremely flexible and adaptable to different calibers, to different thickness of the vein wall, to various hemodynamic situation and type of reflux that can vary from purely aesthetic cases to severe chronic venous insufficiency. And we can vary in balancing the concentration and the amount of foam on one side and the power and energy of laser on the other. If we have a very thin aesthetic saphenous insufficiency, then we can use 0.5% of foam and 4 watt with 35 or 40 joule per centimeter. And then we increase the foam and laser if the caliber goes up. Suggestion for SPHALT. If the obliteration of the saphenous vein is your choice, then let's do it in a gentle way without damaging the surrounding tissue, in a safe and fast way, but above all, with minimum discomfort for the patient and maximum satisfaction. Thank you very much for your attention. About we are not talking about hemodynamic intervention.
Thank you very much, Dr. Zini. We appreciate very much sharing your technique. I could summarize it in briefly. Dr. Zini's technique consists of a combination of foam sclerotherapy together with laser. So he starts by burning at the junction. So he occludes at the level of the junction, and then he injects the foam, which then stays inside the vein, and then he uses laser in the usual way, just using half the values. That's a summary of his technique. Now I'll give the word to Dr. Wasila, if you please introduce the panelists. Dr. Wasila, please.
Yes, I'm here, Dr. Rashad. Thank you. We have the honor to have among us today Professor Jaroslav Stregi. Professor Stregi from Czech Republic. He is the president of the Czech Society of Phlebology, former UIP vice president, president and founder of the Czech Academy of Dermatology, and honorary president of the endovenous section of the Czech Society of Phlebology. Professor Jaroslav, please, your question to Professor Zini.
Thank you very much for introduction, Dr. Taha. I'm very pleased to be here. Dear Professor Bisara, dear Dr. Zini, dear Sergio, dear participants of this extraordinary internet meeting. It's a great honor for me to participate as a panelist. In the same time, I would like to greet you all in the name of the Czech Society of Phlebology as the president, as you already know. Our society celebrates this year 55 years since its founding, which belongs to the oldest societies in the world. And now for my task, congratulations to Dr. Zini, to his method. And I must admit that I did not know much about it yet, even though I know it exists. I studied all the available literature today, but it's not so much of this. I'm sorry, I should have just one question, but we will see how will the contact with Professor Zini work. So I have 5 questions, but you can answer them very briefly. The first question is, how long part of the long saphenous vein should be treated at the beginning of the procedure? 1 centimeter, 2 centimeters? Professor Zini, could you answer this question,
yes,
please?
Yes. We treat veins up to 15 millimeters.
Oh, this would be a problem. This would be a
And
problem.
we take the diameter of the vein 5 centimeters below the thigh.
Yeah. Thank you. The second question is it possible to perform this method really without anesthesia?
Sin anesthesia?
Yeah. Is it, if it's possible to do it really without any tumors and anesthesia?
Of course, the painful procedure is the laser. So if you arrive to not down to 4 or 3 watt and 30 or 40 joules, then you can do that without anesthesia. But you need to have a very thin,
very thin fiber.
saphenous vein.
Yeah, yeah, okay. The next question is, did you do any histological studies with your method to compare them when using just the laser alone?
Well, we are going to do histological studies in this procedure.
Yeah, okay.
What we can say that after 6 months, most of cases, the vein, the saphenous vein, disappear.
Yeah, understand. And what I would expect, this is the last question, the combination of sclerotherapy with foam and the laser energy could produce much more phlebitis than the laser by itself. Is that true or not?
No, I don't think so.
Yeah. Okay, okay.
Because the laser we use, low fluence, and we don't have so many phlebitis.
So, my final comment. I will promise you that I will try your method in a short time, because we have a new laser using 1940, and then you can, with this, you can work just with 1 or 2 watts. So we will combine it, and I promise you, I will let you know by the end of this year if the COVID situation will allow us in the Czech Republic to perform the procedures. So I will let you know how it works. So this is my promise to you and to all panelists and to all listeners to it. Thank you for being with you. Thank you very much. And thank you, Sergio, for inviting me here, because I'm very happy in this field. And thank you, Rashad.
Thank you. We are running out of time.
Thank you very much.
Dr. Yaroslav, it was really our honor. And thank you for all such stimulating questions. It means the message was delivered of Dr. Zini despite the bad connection what we had. Thank you, Dr. Yaroslav, for your stimulating question. Thank you very much.
Thank you, Basila.
Our honor having you among us today, really.
Thank you very much.
Sure. Now we will move to the next panelist, and this is a very important part of our night today because he represents our dear continent, Africa, Professor Martin Forli. Professor Forli is a vascular surgeon, senior honorary lecturer in University of Cape Town, and he is among the executive committee of the Vascular Society of South Africa, VASSA, since 2014 till present, and he was the secretary of the society from 2016 till 2018. Dr. Forli, we are really honored having you among us today, and now if you have any question to Professor Zini, please go ahead. The podium is yours for you.
Good evening, everyone, and thank you very much, Wasila and Rashad, for this opportunity to be part of this international forum. So, and greetings from beautiful Cape Town. So thank you, Dr. Zini, for that talk. I'm very sorry that we couldn't hear you as well. I think conceptually this is an excellent technique because it uses the best aspects of both techniques to enhance the effect on the vein that's being treated. I mean, the use of foam allows less energy to be used, so it decreases the potential ecchymosis and postoperative pain. It avoids the use of tumescent anesthesia, being painless. Also, closure of the proximal part of the vein prior to giving sclerotherapy does minimize the risk of the potential embolic complications of using foam. And also the foam, using foam in addition to the sclero, will treat any refluxing branches. So really uses all the aspects of both to enhance the treatment. So my question is, I've got 2 questions. So one is a technical question. Thomas Prupstal did a lot of studies early on in terms of laser, in terms of the amount of energy that has to be delivered. And he worked out that it needed at least a fluence of 20 joules per centimeter squared, which he worked out to 6.3 centimeters per diameter of vein. So in terms of when you do this, I know that you say you can decrease by 50%, but do you determine that based on the diameter, and do you adjust that the energy setting and the time that you pull back the laser? So that's the first question. And then the second question is really in those very superficial veins. We saw in Professor Kabnik's presentation where you can get, in very superficial veins, you can get pigmentation and burns. Is this something that you could be able to use for those very superficial veins where you could almost see the great saphenous vein? Thank you very much, Professor Zini.
Thank you, Professor, for your question. I must tell you that normally the fluence that are used with laser, traditional laser treatment is more or less 80 joule per centimeter in normal veins that go up to 100 or low down to 70 with 8 or 9 watt. And we use exactly 2%. It means that we use 4 or 5 watt and 50 joule per centimeter. Because we act in a vein in which the endothelium is already damaged by cold. So it is sufficient when very low fluence of laser destroy the wall. And about your second question?
Second question was whether you use it in these very superficial veins. Can you use this technique?
Yes. With the low fluence, you can treat superficial vein, but not less than a centimeter from skin. We have very superficial, just attached to the skin. We just inject serum, the physiological serum or saline, just to lower the vein 1 centimeter.
Thank you, Dr. Zini. Professor Kabnik has a comment. Please, Professor Kabnik, go ahead.
Thank you for the opportunity. Dr. Forley, you mentioned Dr. Postal's work. I think one of the things that we must be careful about is the type of laser we're using, so the wavelength, and also the fiber. The fiber is really important when you look at joules per centimeter or LEED. So they're not necessarily comparable. Now, Jerry's going to tell me differently, but the 1940 wavelength, as we look at it going forward, yes, you can reduce the power, but at the end of the day, he's going to have to increase the joules per centimeter and the time. So having experience with the 1940, there are things that you can do with it, but be careful about the wavelength. It really has to do with power density in the fibers. So the power densities are really important. If you look at the BioLitech catheter fiber, their power densities with the radial fiber are a lot lower than a bare tip fiber. And with that, you need more energy. And the in-between one is the NeverTouch. And the NeverTouch needs more power than the radial fiber, but less than a bare tip. So be careful with all of these.
Thank you, Professor Kabnik. Unfortunately, we'll have to skip the questions from the audience, but I assure you that the questions are recorded and they're going to be filtered later. And now I'll give the word to Professor Oscar Boutini, who is the honorary president of VWIN Foundation and who kindly is going to wrap up the session. Professor Boutini, please go ahead.
Thank you, Rashad, for introducing myself and also for this important invitation to the African webinar which allows me to be among friends in spite of the distance. To make a short summary, I would like to remark to a brilliant presentation we enjoyed today and the following ideas. Recurrence rate remains the same despite technological innovation. SPHALT is an innovation strategy that demonstrated to be safe. SPHALT recurrence rates are competitive in the middle term. Sedation is valued anesthesia option. In my opinion, I prefer use below the knee. EVLA has demonstrated to be safe in the long follow-up. Nevertheless, complications, including severe ones, are possible, and proper management skills are required. EHIT management should be tailored according to the related classification. Finally, I would like to invite you all the next Saturday's RATAF meeting to continue sharing this travel to make us so happy. Thank you.
Thank you, Professor Bottini. Very nice. Dr. Wasila, would you like to present our guest of honor from Egypt? Please go ahead.
It's a real honor to all of us to introduce someone who doesn't need any introduction, in fact, Professor Ali Murad, our guest of honor tonight. Professor Ali Murad is a member of the board of the Vascular Society of Egypt, former president of the society, and member of the Vascular Society of Great Britain and Ireland, member of the Court of Examiners of the Royal College in England, former chief of Vascular Surgery Service of the Egyptian Army. And really, we are honored having you, Professor Ali Murad, today. You are a great and grand icon of vascular surgery in our country, in Egypt, and in the whole region. Thank you for joining us tonight. And now we are waiting for your closing words to the best closing for our tonight today. Please go ahead, Professor Ali Murad, for your closing speech. Thank you.
Thank you, Wasila, very much. Hello and good evening, everyone. I would like to express my deepest appreciation for the board of EVLA for giving me the honor of being the guest of honor for tonight's event. I must also express my gratitude to my dear friends, Professor Rashad Bishara and Professor Wasila Taha, for their efforts and contributions to the educational field of vascular and endovascular surgery. I genuinely enjoyed both last week and tonight's webinars. The level of speakers, panelists, and the contents were all very impressive. The EVLA has a very vital mission, and I am very confident that with the support and cooperation of everyone here today, we can elevate the level of vascular surgery education and the field of vascular surgery in all of Africa. Thanks again, and have a wonderful night. Thank you very much.
Thank you, Professor Ali. And last, I wish to thank our sponsors, our main sponsor, Servier Daflon, our gold sponsor, Medtronic, and our sponsors, Abbott, Biolytic, and ProMed. Thank you for all of them. And I would like to thank you all for all the participants, all the speakers, and all the panelists, and waiting to see you again next Saturday. Bye-bye.
Bye-bye.
Thank you. Bye all. Have a nice evening. Bye.
Thank you.